All right, so this is the conventional aortic anatomy as you all know it. Just bear that in mind as we discuss some variations. That's it, right? All right, go read it in some book. So the innominate being the first branch, followed by the left carotid and then the left subclavian. This is the normal sequence or the usual sequence as you would normally see it. Now the fun part, and I'm going to read it for you. So embryologically, you have to think about it as which arches regress and which ones develop. And the lack of regression in some of them is what's going to lead to some of the variants. So there are 6 pairs of pharyngeal arch arteries that develop in conjunction with the branchial pouches. It's the 3rd, 4th, and 6th, along with the 7th intersegmental arteries and the left dorsal aorta that are the primary contributors to the normal aortic arch. Now, the segments that normally regress include the distal portion of the 6th arch and the right-sided dorsal aorta, and the left 4th arch will become the aortic arch proper, whereas the right 4th arch will contribute to the innominate artery. The left dorsal aorta becomes the descending thoracic aorta if you follow the diagram above, whereas the intersegmental arteries bilaterally will become the subclavian arteries. Now, an aortic ring is one of the anomalies that one might encounter. If the 4th arch does not regress, you can end up with a double arch aortic ring. And the symptoms are most often related to esophageal compression, whether it's a complete or an incomplete type of ring. Similarly, a right arch, which is actually the most common anomaly of the arch, can result from inappropriate regression of the arches and may occur along with an aberrant left subclavian. It can form also a complete or an incomplete ring, depending on the origin of the ligamentum arteriosum. Now, in aberrant right subclavian, you will see it fairly commonly in clinical practice. Now, this is due to an abnormal regression of the 4th arch. Although it rarely produces symptoms, you will see patients sometimes with esophageal compression. The artery itself can become aneurysmal, so you may have to treat someone who has an aneurysmal degeneration of the aberrant subclavian. So most patients will have the so-called normal configuration. 5% will have the left vert coming off the arch. 11% will have some variation of a bovine arch, and about 0.7 to 1% will have an aberrant right subclavian. So 70% of the patient population will have this type of configuration. 6% you have to be aware that may have a vert coming off the arch, and this is important if you're doing a TVAR for a dissection or aneurysm disease. You may end up inadvertently covering that, which you may have to sometimes do if it's non-dominant, but just be aware that you can have that variability, and 1% or so are going to have an aberrant right subclavian. Symptoms, as I mentioned down there, include dysphagia, which is related to esophageal compression, but this vessel can also become aneurysmal over time. Now, the bovine arch, which is a misnomer, can occur in different configurations. It is more common in African American in general, but it can be it can occur either as a common origin of the innominate and the left carotid off the aortic arch, or as a bifurcation of the left carotid from the innominate and the right carotid occurring a little bit more cephalad. A little bit about abdominal aortic embryology. Again, you have to think of it as ventral and dorsal root regression, and depending on the pattern of regression, then you can have some of the variants in terms of the mesenteric visceral segment. So a variant visceral anatomy can occur in about 14 to 18% of the patient population, and it depends on which of the which regression does happen or doesn't happen. The replaced right hepatic artery and the replaced left hepatic artery are the most common, whereas an accessory right hepatic and an accessory left hepatic are the least common configuration. Accessory renal arteries are fairly common as well, and 20% of the patient population can have that. You have to be aware that 15% are unilateral, but 5% are bilateral, although they most commonly occur around the main renal artery. They can also originate more distally off the iliac, so be aware of those variabilities when you're doing either aortoiliac angioplasty and stenting or endovascular aneurysm repair. Sometimes covering many of those can result in renal impairment. Few words on aortic anatomy. As one would expect, the diameter is going to change once you move from the arch further down, and it also varies by gender. The variability by gender is not dramatic, but it's certainly there, and the aorta is going to progressively become smaller as you go down to the infrarenal segment, and it is somewhat smaller in women as compared to men. In terms of histology, the histology is not really that different by gender, but it will change when you move from the thoracic part down into the abdomen. In general, the media is the thickest layer of the aorta, and because of the increased elastin content, the dominant properties of the aorta will include compliance, capacitance, and dynamic compression. The intima, in comparison, is very thin when you compare it to the media, and the adventitia of the aorta has what we call vasa vasora, or small blood vessels, along with collagen. Now, when you move further down the aorta down to the bifurcation, you have a decrease in the elastic lamellar tissue. The collagen level, however, remains constant, but you have progressive thickening of the intima and attenuation of the media, and this may have some implications on why some segments of the aorta will degenerate. Why is it that aortic aneurysm are more common in the infrarenal distribution, and some of the tracings and pressure variability and fluctuance that you see further down the aorta. So this is what I'm talking about here. Although you have a dicrotic notch present more proximally because of valve closure, you're going to see that in the abdominal aorta, the systolic waveform is taller and more delayed, and in the peripheral vessels, it's even taller and more triangular and more delayed because of the increased resistance and decreased amount of elastin more distally. Now, the mean pressure will only decrease slightly as the blood flows distally, but the fluctuation about the mean, which is determined by its stiffness, you'll see it more pronounced as you go more distally into the aorta. And this will also have some implications on the capacitance of the aorta and how much volume it can accept. A stiff aorta will accept a stroke volume at a higher pressure, and it can remodel over time to accept a larger volume at lower pressures. So some angiograms that you might see as you're doing either aortic work or even carotid work. You see here that you have a bovine arch where you have a bovine origin of the left common carotid artery. You also see that you have a left vert of the aortic arch, so be aware of those. Just train your eye to pick them up either on a CT or on an angiogram. And again, an aberrant right subclavian is something that you're going to see relatively often in clinical practice, just because those patients are going to end up being referred to you. Angiography of the aorta, just for aneurysm planning, is really not commonly done because you can get most of the information based on a CT scan, but it can sometimes be rarely useful whenever you have multiple accessory renal vessels, especially in the setting of a horseshoe kidney. So be aware of that variability and how to pick them up whenever you're planning endovascular aneurysm repair. I think this was my last slide, and I don't think we should allow any questions. What do you think? Anyway, I'm happy to answer questions if you have any.